Good evening, everybody, and welcome. It is a fantastic occasion and quite emotional, and we'll hear why that we're in Lecture Theatre 2. So it's a great privilege for me. I'm Roxana Carrare, or Rox. I'm Head of School of Clinical and Experimental Sciences within the Faculty of Medicine. Professor Tristan is a senior member of clinical academic staff within the faculty. The introduction was due to be given by another senior clinical academic who is currently in India. And we've had some technological problems, and Professor Rob Reed, who was supposed to introduce Professor Clark, just sent me a couple of lines that actually summarize everything. And I quote here, "The thing I wanted to say about Tristan is that in the 12 years since his appointment to the University of Southampton and Medicine, he has been a wonderful credit to the university, a fabulous clinician in infectious disease, and a researcher who has beaten his own path and added considerable value and impact to the NHS." So that is a wonderful summary, but to add a little bit more flesh to the bone, Tristan Clark is Professor and Honorary Consultant in Infectious Diseases within the Faculty of Medicine at the University of Southampton and University Hospital Southampton NHS Trust. He graduated in the University of Southampton. His research involves the assessment of novel rapid diagnostic tests for infection. He has been an NIHR postdoctoral fellowship holder and has been awarded grant funding from NIHR, from UK research councils, the EU, and he has strong links with the diagnostic industry. He has over 100 publications in peer-reviewed scientific journals, including New England Journal of Medicine and Lancet series journals. During the COVID-19 pandemic, he was scientific advisor to UK DHSC on rapid diagnostic testing. He's a member of the British Infection Association Scientific Affairs Committee, an editor for Journal of Infection, a panel member of the NIHR Doctoral Fellowship Selection Committee, and a council member for the International Society for Respiratory Viruses. His research, as I'm sure we'll find out shortly, aims to improve patient outcomes and experience through the evidence-based use of rapid diagnostics. I shall shut up now, and I look forward, as we all are, to listening to your talk. And I'm going to welcome you.
Thank you very much. Thank you. So, thank you very much, Rox, for that kind introduction. You've given all the detail now. I don't need to do it all. Thank you very much for everyone coming today. I do appreciate you taking the time out of your day to come and listen to me talk today. And thanks also to Rob, even though we didn't get his recording, the intention was there, so thanks to Rob for doing that. I also need to apologise a little bit to the organisers because, as some of you probably know, I got my chair a couple of years ago actually, and so this inaugural lecture has been delayed, and part of that is my fault because I insisted that I wanted to do it in the lecture theatres rather than the usual venue, which is much smaller. And the reason for that is that over 30 years ago, I was a medical student here, and I used to get lectured. My sister too, in fact, over there. We used to get lectured in this very lecture theatre, and I thought by giving my inaugural lecture here, it would be a nice example of circularity. So thank you very much for indulging me and letting me use the lecture theatre today. It's quite difficult to fill compared to the IDS building, but there you go. And so, as Rox has mentioned to you already, my research is around diagnostics, so rapid diagnostic tests for infection. And so I wanted to start by just reminding everybody what we mean by diagnosis and why diagnosis is important. And diagnosis is defined as the process of identifying the nature and the cause of an illness. And as a concept, this has been around for a really, really long time, so over 4,000 years. But it was really developed by this guy down here, which is Hippocrates, who's famous for being really the forefather of modern medicine. And this isn't really a photo of Hippocrates, because he lived a long time ago. This is an AI-generated image as to what he may have looked like. And so there's a couple of quotes about diagnosis that I like and I wanted to share with you. So this is from Gandhi, who obviously wasn't a doctor, but knew a thing or two. And so Gandhi says a correct diagnosis is 3/4 of the remedy. And so what Gandhi is saying is that, really in order to treat a condition or to solve any problem, you really need to know in detail what it is. It sounds obvious. And then this is a nice quote from a guy called Ambrose Bierce, who's an American writer from about 150 years ago. He's not well known now, but he says a diagnosis is a physician's forecast of disease according to the patient's pulse and their pulse. And I like this because, he's being satirical, but essentially he's introducing this concept that as physicians we may be conflicted, when we are making diagnosis and when we're treating patients. And then there's this quote from a guy called William Osler. Yeah, I'll let you guys read it. So he's known as the great diagnostician. So this is a Canadian physician from, again, about 150 years ago, and he's very famous in medicine, lots of things named after him. And he says this quote, and this really is because he lived in a time when we didn't have diagnostic tests, and so diagnosis was entirely based on the patient history and the examination. And I think what he's trying to say by this is that it was important to be thorough. Okay, so I'm going to come back to diagnostics a little bit later, but I thought I'd just take you on a little journey as to how I got to where I am today. And so my mum and dad will recognise this house in the corner. So this is where we grew up in Bath. This is Hawthorne Grove, and it's made of this nice yellow stone. And we grew up in a place called Combe Down, which is not very well known. It's a little village on the outskirts of Bath, but it's full of quarries, and this is where they quarried all the Bath stone that was used to make the beautiful buildings in Georgian Bath, which probably you guys have all been to, such as the Royal Crescent and the Palladium Bridge there. So it's not well known, but it should be. And so we grew up in Combe Down. And this is my sister and I when we were young. So when I was a little boy, I didn't want to be a doctor. I wanted to be a cowboy. And this is us playing cowboys and Indians in the 1970s, before that was deemed to be culturally insensitive. And this is us playing on the beach in Weston-super-Mare. And we're looking pretty cool there, I think you'll agree. And the thing I remember most about growing up in the 70s and 80s is that I really loved science fiction and the science fiction TV shows, and these were two of my favourites. So this is a show called Blake 7. People don't really remember it now. And this is Doctor Who, and Doctor Who in those days, and will always be for me, Tom Baker. And the thing I loved most about those shows, when I look back, was the technology. And so these are some of the props from Blake 7. There's a teleport bracelet there. We're not quite there with teleportation yet. This is their weapon system, and this is a computer. This is their computer that was called Aurak, and Aurak was an artificial intelligence. So he was a supercomputer, and what Aurak could do was he could gather data from all the other computer systems, this was in the days before the internet, and he could use that to make accurate predictions, and the crew of the ship would use that to make their decisions, and that is what kept them one step ahead of the Galactic Federation. And that's just a quote about technology from Arthur C. Clarke that I always really liked. And so I enjoyed growing up in the 1970s and watching my science fiction TV shows, but then I had to go to secondary school, which I didn't like quite as much. And I went to this school which is called Beech and Cliff, and this is a state school in Bath. And I was looking at the alumni page the other day for Beach and Cliff, and I realised actually there's a lot of famous people that went to this school. I didn't realise it before, but there are, and some of you might recognise some of these people. People know who this is, so I'm told that it's quite a popular show that he's in at the moment. This is a guy called Andrew Lincoln, but his real name is Andrew Clutterbuck. Andrew Lincoln is his stage name, and he's been in a few things, but he's most famous for this show called The Walking Dead. Nobody watches it. I've never seen it, but I've been told it's really popular. And this is Andrew and I. That's me there in the school play in 1986, which was Oliver, and he's playing the Artful Dodger, and I'm one of Fagin's boys. And then there's some other really interesting, famous people from the school as well. This guy is Kurt Smith from the band Tears for Fears. Anyone knows Tears for Fears? And this is Dan Rivers. So he was a friend of mine, and he's now a correspondent for ITV News, so he does their war correspondence. And then this is probably the most famous alumnus. Does anyone know who this is? The sort of pose gives it away a little bit. It's actually Roger Bannister. So, famous for breaking the 4-minute mile. And he came to talk to us when we were at school. And so, I didn't really engage at school very much for a lot of the time I was at secondary school, and I didn't do that well, which was a constant source of irritation, I think, to mum and dad. But when they split the sciences, when we did GCSE, chemistry, maths, chemistry, physics, and biology, that's when I really started to enjoy it, and I particularly loved chemistry and biology. And what I loved most about it was experimentation. In other words, proving theories and proving natural laws with reproducible experiments. And eventually I did quite well at school, and I got reasonable A-levels, and I got offered a place at Southampton University. I had to defer a year because my predicted grades hadn't been very good, and so I spent a year working in the medical records department of the Royal United Hospital, Bath, and then afterwards I came here in 1993. And we were just talking about this before I started, but in those days, the undergraduate medical degree, the first 2 years was here at Boulderwood. So Boulderwood still exists, but it's now used for something else. But we all remember Boulderwood, really fondly. It was a great little place for us to go. And then we used to come to the hospital to see some clinical stuff on the Thursday. Because it's quite a long time ago now, it's over 30 years, I don't remember everybody, but there were some superb educators there and some standout people. And this guy, Alan Thomas, who was the Dean of the Admissions, you probably remember him, he was a really nice guy, and one of the reasons I'm here. And then this guy here is Patrick Gallagher, and he was my tutor in the first year, and I have to say he was just a fantastic tutor and a fantastic educator, and he really brought all the cases to life, which was particularly ironic because he was a pathologist. And one of the interesting things about the medical school in those days was that they were an early adopter of what we call early patient contact. And so this meant that even as a first-year medical student, we would go on these adventures and go and see patients and go and see these really cool people with interesting diseases. And so we went and saw one of the last patients in the UK that was in an iron lung. So this is somebody that had caught polio and was paralysed, and he had to sleep in this iron lung every day of his life. And we got to go and see him and talk to him, and we even had a go in his iron lung, which I have to say was utterly terrifying. And so the other thing I really liked about being a medical student here was being in the Medics Review, which was the show that we did every year. And I was in the cast for the first 3 years, and then in the fourth year, myself and my friend John Lacey directed it, and it was called Euro 96 because, there was the Euro 96 the same year. And these are two neurosurgeons that used to teach us neuroanatomy. That's Peter Lees and Fausto Iannotti. And they were always up for a laugh. And then this is us in the pub practicing our songs, which must have been very irritating to anybody else who was in the pub at the same time. You might recognise one of our colleagues up there. That's Jay Self, who's associate professor in ophthalmology. And this guy here Dan Lashbrook. So he was a very talented musician, and he went on to become a GP. But a couple of years ago, he became a member of the West Country folk band, the Wurzels. And so, so he now tours with the Wurzels. So, Southampton Medical School, it turns out some great doctors, but it also turns out some really great pop stars. And so, I qualified in 1998, and I went on to do my house jobs. And I did my house jobs I did my medical house job in Poole and my surgical house job in Portsmouth. And then because I knew I wanted to be a medic, all the way through, and I did my medical SHO jobs in Portsmouth. And the thing that I remember most about them is, just how hard we worked and just how many hours we worked. And, that really is the defining thing for me. And people may remember there was a bit of a scandal in the 80s about junior doctors' hours, and they passed legislation to mean that you couldn't work more than 72 hours in a week, which is a lot. But it was also averaged over 4 weeks, and so what that meant was that we often worked over 100 hours in a week, including the entire weekend, with no protected rest. So we were always really tired. And in the end, it was actually the EU that sorted it out for us because of the European Working Time Directive. And that's really what made the difference, and suddenly things became much easier. And if you want to know what it was like being a junior doctor in the late 90s, this programme, Cardiac Arrest, was really, really good and really accurate. It's a dark comedy by this guy called Jed Mercurio, who's done a lot of TV. And it wasn't particularly popular, but it is pretty accurate. And so I did my medical rotation, and I always knew that I wanted to do infectious diseases, and so I ended up doing the diploma in tropical medicine in Liverpool, which was excellent. But then I thought it would be fun to work for Médecins Sans Frontières, which is an NGO. And so I signed up with Médecins Sans Frontières. I did my 2 days of training over in Holland, and then they assigned me to a hospital in this little place called Bentiu that I'm sure people won't have heard of. You can see the arrow points to it there. So it's now in South Sudan, but in those days Sudan was a single country, and there was a war between the north and south, and pretty much where the border is now with the kind of front line. And so Bentiu was on that front line in a relatively unstable place. And this is what's called a tukul. So this is the sort of traditional mud hut where where all the patient's family lived. And that's where we lived as well. So we lived in tukuls. This isn't mine, but mine was very similar. And all the hospital buildings were kind of bigger versions of these as well. And they were incredibly hot, and they would often fall down after heavy rain. And so, as well as treating the usual kind of things that people get in that part of the world, like malaria and pneumonia and dysentery and all these things, we also ran a big TB program in Bentiu because there was a lot of TB there, and also a Kala-Azar program. And Kala-Azar, which is also known as visceral leishmaniasis, is a parasitic disease that's spread by sandflies, and it's endemic in that part of the world, and it's fatal, 100% fatal without any treatment. So MSF had set up a treatment there, and this is me doing my ward round in the paediatric Kala-Azar clinic. And we used to treat people with this drug called SSG, which is a very old-fashioned drug, quite a toxic drug, that's made from antimony. And it did cure most people, but it also killed some people as well. And this is Georgie Beng, who was one of the nurses there, and this is them preparing all their SSG shots for the Kala-Azar patients that were coming in that day. And you can see them lining up all the injections there. And so people with Kala-Azar used to get treated with a daily injection of SSG in their bottom for 30 days, a very painful injection. And often that would work and cure them, but sometimes it didn't, and so then they'd get another 30 days. And so, it was hard work working in Africa, even harder than being a house officer in the NHS. And after that, I came back to the UK, and I wanted to get a national training number in infectious disease and general medicine, but the problem was there really weren't very many of these numbers, and they didn't come up very often. And so I applied for a few, but I didn't get them, and they went to internal candidates. And so in the end I got a bit bored, and I went to this place, which is Darwin in northern Australia. And Darwin was kind of famous in ID circles because it's in Australia, but it's got a tropical climate, and therefore you get some really interesting tropical diseases. And so, my wife and I went to Darwin, and I worked there for a while, and this is Darwin Hospital, and it's the only hospital I've ever worked at that had an Olympic-sized swimming pool. And it was great, because it was so hot, what you could do is go to the swimming pool before and after work to cool down. And this is a picture of me being a proper Australian, and camping out in the outback and having a big old fire. And so the other interesting places that they had in the Northern Territories were these really big natural water holes. And these are amazing places, and they look really inviting, particularly as it's so damn hot. But the problem was, you would go there and get ready for your swim, and then you would see these signs that would basically say, there are two types of crocodiles here. One's really dangerous and one's a little bit dangerous, and you can go swimming, but you might get eaten by a crocodile. And so it's difficult to completely enjoy your swim after having read these signs. And as I said, there are some interesting tropical diseases that you get in Darwin. I can see we've got some ID colleagues in the audience there. So does anybody know what this is? It might be helpful to say that this person also has gram-negatives in their blood culture. Adam knows. Melioidosis, yeah. So it's kind of, Darwin is famous for that. So this is a condition called melioidosis, and this is a soil living organism. And the theory is that after the heavy rains, all the organism, the Burkholderia pseudomallei in the soil gets aerosolized, and then people breathe it in and it causes pneumonia. And it was particularly the Aboriginals that used to get this because they live quite an outdoor existence, and they're often immune compromised because they've got diabetes or CKD. And this is the organism on some selective media. Anybody know what this is? This is another disease that's endemic in northern Australia. Nick or no? It's not dengue. Not dengue. I mean, they do get dengue as well. You're right. Yeah, it's probably a less well-known disease actually. Anyone? It's very similar to tick. So this is Ross River fever. Yeah. So this is an arbovirus disease. So this is a viral infection that's spread by mosquitoes in that part of the world, and people get a fever and a rash, and sometimes a really nasty polyarthritis, mainly involving the hands. So yeah, clinically it's very, very similar to things like chikungunya and parvovirus. And so, we had an interesting time in Darwin, and I did think about staying there to do my training, but in the end I decided to come back to the UK, and on the way back we stopped off at this place. This is a place called Kuching, a really beautiful place, one of my favourite places in that part of the world. This is in the Borneo part of Malaysia, and we stopped off there because we had a friend who was studying Plasmodium knowlesii, which is the fifth type of malaria that people and macaques get. And this is a picture of my wife by the waterfront. And while we were there, I managed to log onto the internet, which was not an easy thing to do in that part of the world, and I saw that there was a national training number that had come from Leicester in the UK. And so using some rather terrible printing facilities that we found on one of these street stalls, I managed to print out an application form and a CV, and I posted it off, and lo and behold, I got shortlisted for the job. I went for interview and I got it, and so I got my training number in Leicester. And Leicester's famous for a few things, probably most famous for Gary Lineker and for Walker's crisps. But what I didn't really appreciate when I went for that interview is it's actually famous for some other things too, and it's actually the most ethnically diverse city in the UK. And so white British people make up about 40% of the population in Leicester, and ethnically Indian people make up over 40%. And so it's a really diverse city, and this is that's the Diwali celebrations in the centre of Leicester, which are some of the biggest Diwali celebrations anywhere in the world. And so I guess because of this, it's also got the highest incidence of TB in the country. And so I guess what I would say is that I got excellent clinical training in what I would say are the giants of ID, so in TB, HIV and in viral hepatitis. And when I was there were three consultants in infectious diseases. This is Martin Wazelka, Carl Nicholson. I couldn't find any picture other than the black and white one, sorry Carl. And this is Ian Stevenson. It was just an excellent place to get trained, and Martin was my educational supervisor, and I couldn't have had a better supervisor. He was just a really astute clinician, but also a really nurturing educational supervisor. And then Carl and Ian, they were the academics, and they really encouraged me to do research, and they kept petitioning me to do research, but I was just really interested in doing my clinical training. But after a couple of years, I got bored of saying no, and I capitulated. And obviously, I'm really glad that I did. And that's where my research career was born, really. And because of the research that was going on in Leicester at that time, which is around avian influenza vaccines, I got to meet some other really interesting people. And so this is Maria Zambon, who became director of the Reference Microbiology Lab in Colindale. And I think everybody knows who this is now. He's become a household name. This is John Van Tam, who was, of course, Deputy Chief Medical Officer during the pandemic. And the research that Carl and Ian were doing at the time, as I said, was about was around H5 vaccines, so avian influenza vaccines. And this was because in the late 90s there had been some outbreaks of avian influenza of H5 that had caused a number of deaths in people, including some deaths in children. And people were very worried at that stage that this was going to cause the next pandemic. And what Carl and others had found is that the problem with the H5 virus, with the H5 antigens, is they're actually very poorly immunogenic. And so in order to elicit an immune response, you need really big doses of antigen or to give multiple doses of vaccine. And this is exactly what you don't want in a pandemic, where you want to vaccinate everyone really quickly and you want your antigen to go as far as possible. And so he and others came up with this idea of the prime boost vaccination strategy. And so this is where you vaccinate your population with one strain of H5 before the pandemic is at your doorstep. And then you boost with a second dose of a different antigen when the pandemic actually arrives. And by doing that, you actually generate really robust immune responses. And so everyone loves this picture. And so we did get a pandemic in 2009, but it wasn't with avian influenza, it was with swine flu. So everybody was worried about H5, but in the end it was something different. And in the early days of the pandemic, we really didn't know very much about how the swine flu would behave biologically. So people may remember that influenza is really interesting as a virus in that it has a segmented genome. And what this means is that if you get different strains of flu that infect the same cell, it can actually mix up all the genes, a bit like shuffling a deck of cards, so that you can get the emergence of novel strains. And pigs are actually the perfect vector for this because they can be infected by avian influenza, human influenza, and their own porcine influenza. And you may remember that the pandemic was actually a triple reassorted virus. And this is a picture that I found when I was putting this together of Barack Obama getting his influenza shot early in the pandemic to encourage the US population to get vaccinated. And I saw this and I thought, how times have changed. But yeah, we didn't know how this was going to behave biologically at the time. We didn't know how dangerous it was. And it turned out, thankfully, to be not as dangerous as other pandemics. But we didn't know whether you'd need big doses of antigen to generate an immune response or multiple doses of vaccine. And this was really, really important to know at the time. And so because of the work that had happened in Leicester before and the relationship that they had with the vaccine manufacturers and with UKHSA, or PHE as it was at the time, we were able to put together and do really quickly the very first influenza vaccine trial against H1N1. And thankfully, this showed that actually conventional doses of vaccine were fine, and you only needed a normal dose of antigen, and you only needed one dose of vaccine. And this, went on to inform UK vaccine policy. And so, I really enjoyed taking part in those vaccine trials, and I went on to do an MD alongside my clinical work, and I did something, related to that but different. In these days, PCR was just becoming the gold standard for diagnosing respiratory viruses, and we did some work with colleagues at PHE Cambridge. This is a guy called Martin Curran, and what they were doing was generating one of the first multiplex PCR panels, the ones that we used, all are familiar with using today, that have got all the different viruses on them. But in those days it was novel. And what we then went on to do was test about 800 patients who came into hospital with acute respiratory illness with one of these multiplex panels. And what we found out was something that wasn't brilliantly well known at the time, which was really the enormous burden of respiratory viral disease in that hospitalised population, and in particular the dominance of rhinovirus. And we went on to do some sequencing of the rhinovirus samples from that study, and this is a phylogenetic tree on this side, which really just demonstrates the enormous genetic diversity of the rhinovirus strains that we identified from this study just in one geographical location in a relatively short space of time. And it includes the what was a newly described type of rhinovirus, which is rhinovirus C there, the one in pink. And so this is why we've not been able to develop a vaccine for rhinovirus, because the immunity is strain specific and there's just so much diversity. So I finished my time in Leicester, and although I think the consultants were quite keen for me to stay, but I really wanted to go and see some new places, and I really wanted to come back to the southwest, which I considered to be my spiritual home. And so, the problem was at that stage there were no infectious disease units in the south, and no infectious disease physicians. And so what I did in the end was I took what was essentially an acute medicine job as a consultant in Cornwall. And I had this idea that I would develop infectious diseases services there, and I would network with other ID centres, and I would bring trainees in and all the rest of it. And I was there for nearly 2 years, and what I would say is I saw some really good infectious diseases there while I was there, and I guess because I was the only ID trained person in that region of the world, all this stuff tended to gravitate to me, and we saw some really cool stuff. And so this is just a sort of smattering of some of the things that we saw, and this is a wet prep of somebody's stool. So this is a patient that had previously lived in Southeast Asia, and then as a much older person had been given steroids for a chest infection, and then had become really, really unwell with severe diarrhea. And this is a wet prep of their stool, and because it's a photo you can't see it, but all these little worms are motile, so they're moving about. These are all larvae, and ID colleagues, you know what this is? Yeah, so strongyloides hyperinfection syndrome. So this was a little old lady sat on the medical admissions unit, and so we gave her some ivermectin, and she was okay. We also saw quite a lot of severe malaria, because lots of people in Cornwall actually work in other places and then come back to Cornwall for some of the year, because there's really not very much work in Cornwall outside of the tourist industry. So we saw a lot of imported malaria, a lot of which was severe because of the delay in diagnosis. This is a guy with an amoebic liver abscess. So this is a young guy that was working on an oil rig in Gabon, who came back with an amoebic liver abscess. And this is a colonic biopsy from a guy that had been diagnosed with inflammatory bowel disease because he got intermittent bloody diarrhea, and he hadn't travelled for a while. He hadn't travelled for about 20 years. But he ended up getting restaged because he moved hospitals, he moved locations, and that's his colonic biopsy. Anybody? I mean, it's not a brilliantly clear picture, but can you see these things here? Anyone know what these are? Yeah, I can hear whispered answers. So these are Schistosome eggs, yeah. So this guy's actually got chronic GI schistosomiasis, which he's had for 20 years, misdiagnosed as inflammatory bowel disease. And these are eggs of Schistosoma mansonii. So we gave him some praziquantel and he never had diarrhea again. And so, yeah, we saw some cool stuff in Cornwall. And then one day, I was on the medical admissions unit, and the South African haematologist phoned me up. I won't do the accent, but he said to me, "Yeah, I've got this bone marrow biopsy from this patient who we thought had lymphoma because he's coming with fevers, night sweats, and splenomegaly. But I think I see some parasites on his bone marrow biopsy. Have you got any experience of Calorazar?" And I said, "You know what? Actually, I do." So I went down there and I had a look at the bone marrow biopsy, and sure enough, he had amastogotes of Leishmania on there, and we confirmed it with PCR. So he had visceral leishmaniasis, and he'd actually acquired it in southern Spain. So leishmaniasis, as well as being endemic in Africa, is actually endemic in the Mediterranean as well, where it's endemic in the feral dog population. And he had a holiday home in Spain, and that's where he'd acquired it. And so we treated him with some Ambizone, and he got better, and he was fine. And he was actually a local actor, and so this is him doing a one-man version of Great Expectations at the little theatre in Penzance. And my wife and I went to go and see him after he was cured of his leishmaniasis, and yeah, it was excellent. It was really good. And so it is utopia, yeah, it is you. So, you know, we enjoy living in Cornwall, and there are some amazing places. This is the Minack Theatre that you guys have probably been to, overlooking Porthcurnow now. But it became clear to me after about 18 months that I wasn't going to be able to realise my dream of developing infectious diseases services there. And the Royal Cornwall Hospital was very much a struggling hospital and a struggling trust, and they certainly didn't want me encouraging more patients, you know, to be coming in from other places. And so at that stage I decided that probably it was time to look for another job. But we got some very fond memories of living in Cornwall, and this is a picture of when young Toby was born. And as luck would have it, at the same time I got an email from Martin Wazelka saying that this man, Rob Reed, who probably most people in the room know, famous professor of infectious diseases from Sheffield, who I knew from my time in Leicester, he had moved to Southampton, setting up research there and also a clinical infection service, and he was looking for colleagues and looking for a senior lecturer. And so I sent him an email, I sent him my CV, and he liked it because it had all these publications on it from when I was in Leicester, and he invited me to come down. And so I met some other, you know, really nice people. I met Radko and Donna, and I also met people like Julian Sutton and Sarah Glover, who would become my clinical colleagues. I'm afraid I couldn't find a picture of Sarah, sorry about that. And yeah, so I applied and I got the post. And so, yeah, there I was in 2013 as senior lecturer and consultant in infectious diseases. But the problem I had was that I didn't have a research programme. So I still had some things left over from my time in Leicester, but it was clear that those were going to dry up. And so I needed to pivot and do something else. And I'd always liked these rapid diagnostics. So this is a picture of lateral flow tests that everybody became familiar with during COVID. But what you may not know is that they've been around for about 20 years already. So these are flu lateral flow tests, and we'd used them for studies in Leicester, transmission studies, you know, when we really needed to know at the time whether somebody had flu or not. And it was always curious to me as to why these hadn't been used more widely. And so this brings me on nicely to the sort of whole reason why we need diagnostic tests for infection. And it seems obvious, but sometimes it isn't. And this is because for a given infection or a given infection syndrome, you can't really reliably tell what pathogen somebody has. So if somebody has acute respiratory illness, you can't tell clinically whether they've got flu or another virus or something completely different. And so this is why we need a diagnostic test. And we need that to inform the patient management, so to find out what they've got and what treatment they need, but also we need that to protect other patients as well from transmissible infections. And this is particularly pertinent when people come into hospital where there are lots of frail, vulnerable patients there. And to exemplify what I said about not being able to tell clinically what people have got, this is a study from the US examining the performance of physician-diagnosed influenza. So this is one study, but there are loads of others, and they all show the same thing, which is, basically if you diagnose people on a clinical basis, you miss the majority of cases of influenza, plus you also diagnose influenza in people who don't have it. So the performance of that is really poor. And this is why you need diagnostic tests. And so if you stick with influenza as the example, this is our, our traditional diagnostic pathway. So for somebody coming into hospital in the winter where we think they've got influenza, what would normally happen is we would do a swab and we would send it to the lab. But it would take about 24 hours for that test to come back again. And so what that meant is that you couldn't use that result to inform your decision making in real time. You had to make all your decisions based on clinical judgment. So decisions about antibiotics, decisions about antivirals, decisions about whether they should be put in single room accommodation to stop transmitting it to other people. And then you'd have to review those decisions when the lab test came back 24 hours later. But I've already told you just how terrible, clinician diagnosed condition, just how bad we are at diagnosing these things. And so what then happens is, because most of the time we get it wrong, it means that we end up overusing antibiotics, which then drives antimicrobial resistance, giving the wrong people antivirals, and not using our single room accommodation appropriately, which leads to hospital-acquired infection and also poor patient flow. And so, the point of a point-of-care test in that pathway is pretty obvious. When somebody comes to the hospital with suspected flu, you do a point-of-care test, and that will tell you in real time or near real time, what they've got. And then you can use that result to inform your management decisions, and it will stop you from making all those mistakes and driving all those negative effects. And so around this time, there was a sort of technological revolution where people had started to put PCR into these boxes, where you could put your sample in, press play, and then get an answer out. And so these boxes could be used as point-of-care tests. But what we found is that there was actually really no evidence base there, no high-quality evidence to show what the impact of that was on patient care. And so I decided that what I would do is I would fix that, and I would do a big randomized control trial where people would be randomized to point-of-care testing for viruses or to routine clinical care with lab tests. And this is the platform that we used in the end, which is called the film array. And this was, difficult to explain just how ahead of its time it was in 2015. But this is a PCR test that tests for the whole range of respiratory viruses in a single test in 1 hour. And it was in this small footprint analyzer. And so, we decided that we could use this as a point-of-care test. And around this time, Saul Forst, who's director of the clinical research facility, he came to me and said he's got this great new guy that started as one of their research fellows, and this is Nathan Brendish here, who was helping them with their clinical trials, but he wanted to do a PhD. Did I have any ideas for research studies? And I said, actually, I think I do. And so I met with Nathan and we talked about it, and I talked about my ideas of doing this point-of-care testing trial, and he was very interested and very excited. And so he and I put the protocol together and built a team together, and really our long-standing research partnership was generated at that stage, and we've been working together ever since. And so we brought on lots of people to help with that study. This is Sean Ewings, who became our statistician, who came from the RDS. We managed to convince Christine McGrath, who at the time was the director of R&D, to give us some money to allow us to do the study. We also got Claire Rook, who was from the CRN, to help us get the study on the portfolio, which liberated a lot of resources that we used for the study. And this is Sandy Aitken, who was our lead nurse and who was excellent. And we also got some support from this lady here, Beth Lingenfelter from Biofire. So we had our team together and we got approval for the study, and we ran the study over 2 winter seasons, and we called it RESPOC. And yeah, we did it, and lo and behold, it showed that point-of-care testing for respiratory viruses was associated with a load of clinical benefits compared to laboratory testing. And we managed to publish this in Lancet Respiratory Medicine, and it's done very well. It's had over 300 citations, and it's seen by a lot of people as an important bit of the evidence base for moving on point-of-care testing. And so around this time, Rob Reed encouraged me to apply for an NIHR fellowship. And so I did. And these fellowships are they're there to support researchers and to sort of train them in new methodologies, but they're built around a study. And so the study I chose was to do an influenza-focused randomized control trial. So we'd seen some interesting signals in RESPOC about the impact on flu management, but there weren't enough patients with flu in that study. So we decided to do a flu-focused study, and that's what I applied to do. And I applied to the NIHR and was rejected. And so I spoke to Rob, and he said, well, these things happen, you should apply again. So I applied again the next year, and I was rejected again. And so I said to Rob, what should I do? And he said, I don't think I've ever heard of somebody applying 3 times with the same project. So you might want to think about that. And so I applied again and I got it. And I guess the message is that sometimes you need to be really persistent, and eventually somebody from the NIHR will see the merit in what you're trying to do. And so I got the fellowship, and it was incredibly important for me because it gave me the time and the resources to expand the team. And so this is Ali and Kate, who became clinical fellows and worked on these trials, and we were able to put together a portfolio of several trials looking at point-of-care testing for different infectious diseases in a range of different scenarios. So in the end, we set up 3 or 4 trials, and this is Laura Presland, who became one of the lead nurses for the flu trial. And so we did the FluPox study, which was a sort of flu-focused version of RESPOC. And again, we managed to publish this in one of the Lancet journals. And I'm very proud of this study. And it showed what we expected it to show, really, which was that point-of-care testing delivered results much more rapidly than lab testing. But it's the impact of that on the antiviral use and the other things that are important. So this just demonstrates that it hugely improved antiviral use for flu in hospital. And it is the same story for isolation facility use as well. So on these time to event curves, it's the blue line that represents those patients that were point-of-care tested. And it made a huge difference to appropriate isolation facility use. And interestingly, we also saw a signal that it improved patient outcome. And this is using one of these ordinal scales that became popular during COVID. So patients that were point-of-care testing actually were less likely to die and less likely to end up in ITU, presumably because they got early directed antivirals. And this is the first study that I'm aware of that showed an improvement in outcome with point-of-care testing. And so we then went on to do some other studies in other types of infection. So this is GastroPoc, which was a randomized controlled trial of using point-of-care testing for GI pathogens. And we did this in partnership with our gastro colleagues. This is my friend and colleague Marcus Vigner down there. He's one of the gastroenterologists here. And with patients coming into hospital with gastroenteritis, it's a slightly different problem in that everybody who comes in with diarrhea goes into a single room. And this is our public health guidance. But the problem is that lots of those patients don't actually have an infectious disease. They have diarrhea for other reasons. And it means that all of your single rooms get taken up by patients who don't really need them, and it takes several days for the lab results to come back. And so it's one of the sort of perfect places where you would think point-of-care testing would change the pathway. And indeed, our study showed that we reduced the time to results from nearly 2 days down to just under 2 hours, and this was associated with a huge improvement in the use of side rooms, so a reduction in side room use by 30%. And you have to bear in mind that side room use is such an important issue for patient flow in hospital. And we also then went on to do a study looking at patients with pneumonia in the ICU. And this is Steve Poole, who was one of our registrars, and he led on that study and he used it as the basis for his PhD. And that study again showed that with point-of-care testing with a pneumonia panel, it led to improvements in antibiotic use. And so we did all these studies that showed the benefit of molecular point-of-care testing for infections, and we were in the process of, trying to disseminate this knowledge and trying to move things forward nationally when this happened, the COVID pandemic. And so in the early days of the pandemic, we saw lots of patients coming into hospital, lots of patients coming into ICU, and really overwhelming health systems in other parts of the world. And people weren't sure whether this was going to come to the UK or not right at the beginning. I mean, we all know that it did now, but at the time we didn't. And so the executive team asked me to come and brief them on this because they knew that I was well connected with UKHSA. And in fact, Nathan was on secondment there at the time, so was getting, real-time updates on it. And also, this was just after our second child had been born. This is Dylan. Hello, Dylan. And so I went and briefed the executive team, and I have to say, they didn't really want to hear what I wanted to tell them, and I didn't get the impression that they'd really taken it that seriously, with the exception of this guy, who's Derek Sanderman, who was our medical director at the time, and he did get it, and he did see what was about to come. And this is a picture of me having shaved my beard off, because of course the masks don't fit if you've got beards, and if you wear a mask that doesn't fit, you might get COVID, so I had to shave my beard off. I don't look very happy about it. And then with the COVID pathway, so the problem we had with COVID was we had all these patients coming in with acute respiratory illness, so with suspected COVID, and some of them had COVID and some of them didn't. And the way that it worked is these patients were being held in assessment areas whilst waiting for their test to come back. And the problem is, because we don't have enough single rooms in the hospital, lots of these patients were being kept in shared areas. And this is, of course, a real problem when you've got patients with a highly transmissible infection that may be lethal. But it's what we had to do, and it's what was happening everywhere. And then when the test results came back, they would be moved to their definitive area. So if it was positive, they'd go to a COVID ward, and if it was negative, they'd go to a clean ward. But the problem we had was that the turnaround time of laboratory testing was really very long. And you can see this is the number of hours that it's taking for the test to come back. And you can see at the beginning of the pandemic, it was taking about 5 days to come back because we were having to send the test to a reference laboratory. But even when we brought the test in-house, you can see that it was still taking about 24 hours to get the test result back. And you can imagine the impact that this has on hospital-acquired infection and patient flow. And so this was another really obvious example of where a point-of-care test would be transformative to that pathway. And so what Nathan and I did is we set up a trial, the COVID-19 POC trial, and this is just a timeline of events just to show how rapidly and how agile we were able to be in those days because of lots of changes and lots of resources that were made available to us in terms of setting up the study and then actually completing it. So from the public health emergency being declared to us actually starting the study was about 6 weeks, and then from starting it to completing it was about another 6 weeks, and we recruited 500 patients. And people in the audience, Radco people, will remember this time. And we didn't use the film array this time because they weren't able to put SARS-CoV-2 onto their platform very easily. That took them a long time. And so we ended up using a test called the QIAstat, which is made by a company called QIAGEN, because they were the first company off the blocks that had been able to put SARS-CoV-2 into their test. And I managed to convince their chief medical officer to give us 500 test kits. And so, off we went and we did the study. And I think there's several people here in the room that were involved in recruiting the patients to that. And, I take my hat off to them because at the time we really didn't know, how dangerous COVID was and what a personal risk it was to us. And the hats off to the team for for going out and recruiting all those patients. And sure enough, we showed, as we expected, that point-of-care testing managed to reduce the time to results significantly. So you can see here that we were able to get a result back in under 2 hours with point-of-care testing compared to about a day with laboratory testing. But really it's all about the impact of that on the pathway, and that's what's shown in this time to event curve. This is the time that it takes a patient from presentation to go to their definitive clinical area, so either a COVID ward or a negative ward. And you can see just what a massive impact point-of-care testing has on that compared to routine clinical care with lab testing. And you can imagine the downstream effect that would have on patient flow and on hospital-acquired infection. And so senior people at the Department of Health and UKHSA heard about the trial, and we got to present it to some senior people, including John Van Tam, who was Deputy Chief Medical Officer at the time, and people like Maria Zambon. And they looked at the results and they got it and they liked what they saw. What you have to remember is that until that point of care testing was not part of any pandemic plan. So if you look at the pandemic plans that were drawn up before COVID, point of care testing is not in there. And this is because lots of senior public health figures in those organisations were actually pretty sceptical about point of care testing. But when we showed them the trial results, I think finally the message got home, and they could see the effect that it was having on the patient pathway, and particularly because this problem of hospital-acquired infection was starting to rear its head at that stage. And so following that, certain things happened. So I was invited to take part in this Academy of Medical Science report, which was about informing the government about preparing for the coming winter, which everybody knew was going to be a big problem with COVID and possibly with flu and other things as well. And so in that, I really laid out the case for point-of-care testing. And I was also then invited to be seconded to DHSC and to join a group that would procure and deploy all these point-of-care tests for SARS-CoV-2. And so we did that. It took 6 months, and it was a pretty tricky journey, but we did that, and we deployed rapid diagnostic tests into emergency departments across the country. And it had a big impact on hospital-acquired infection. And I also got to join several other national COVID groups. So this is a guy called Mark Wilcox, who's quite famous in infectious diseases circles, and so he was the chair of the Technology Validation Group, and this was the group that was set up to assess the accuracy of novel tests for COVID that were being developed and rolled out. And this is the testing TTOG, Testing Oversight Group, which was chaired by Stephen Powis, who's the medical director of the NHSE. And yeah, it was really interesting being on those groups and seeing how things were done. In the trial that I showed you, we weren't able to directly measure the impact of point-of-care testing on hospital-acquired infection. But subsequently, what we did is we rolled out point-of-care testing for COVID at UHS, initially using the QIAstat and later with some other platforms. And what we were able to do with colleagues from the informatics unit is we were able to collect a lot of data and show the impact of this on the risk of hospital-acquired infection. And as you can see from this, time to event curve, you can see that point-of-care testing was associated with a massive reduction in hospital-acquired infection compared to lab testing. And there's some, projected figures for the impact that had in the second wave. So preventing around 140 cases of hospital-acquired COVID and around 35 deaths. And this is some national data at the time, really showing that in terms of hospital-acquired COVID rates, at that stage, UHS was really one of the trusts with the lowest rate of hospital-acquired infection. And this was a time when we were pretty much the only trust that had rolled out point-of-care testing for COVID in our medical pathways. And it's a very telling slide, I think, because you can see from those bar graphs there from the south of England and from the national picture that actually a huge proportion of our cases of COVID particularly in those early days, were hospital acquired, over 50%. And it's a story I feel that was never really properly told. And it really comes down to our NHS estates, and in particular, the lack of single room accommodation that we have. And so I'll skip through these, but we also set up some other point of care testing pathways in the emergency department to help with the triage. We also ended up rolling out GI testing after the COVID pandemic to help with our side room use in MAU, and this is Nikki White from the lab, who's been completely instrumental in rolling out point of care testing for GI pathogens, which has had a major impact on our side room use and on avoidance of bay closures throughout the trust. But in terms of where we go next with our point of care testing research, antimicrobial resistance, as people know, is one of the biggest threats to global human health at the moment, and so measures to combat this are a real priority. And the problem is, although the point of care testing that we do for respiratory viruses has lots of benefits, what it doesn't really seem to do is reduce unnecessary antibiotic use. And this is probably because of concerns over bacterial co-infection. In other words, just because you identify a virus, doesn't mean that there's not bacteria there. And this is a meta-analysis that we published last year that demonstrates that. And so the answer may be these tests, which are host response tests. And so what these tests do is they look at the immune system, and the immune system responds differently to bacterial infections and viral infections. And so by interrogating this, we may be able to tell, accurately whether people have got a bacterial infection or not, and therefore prevent unnecessary antibiotic use. And probably the most interesting of these is this one here, which looks at gene expression, to get its readout. And so what I'm planning to do over the next few years with my colleagues and my fellows is that we're going to do some trials looking at the accuracy and the impact of these tests. And you have to take this in the overall context as well. And what you may not know is that the diagnostics market has had huge growth after COVID, and in particular the point of care diagnostics market. And this is due to be worth over $100 billion in the next few years. And some people think it may even rival the pharmaceutical industry, by 2050. And the problem we have in the UK is that we're really not very good at assessing these tests or at deploying them. And so this is something that we need to sort out in the context of this revolution of point of care testing. That being said, if people were to ask me, what I think about the future of point of care testing, I think it's actually, very optimistic. And what I think we're going to see over the next few years is a lot more testing in primary care. And it's been, really great working with people like Nick Francis here in the primary care sphere to try and gather some of that evidence for the impact of point of care testing in primary care. There's also lots of really exciting new tech as well. So there are these analyzer-free PCR tests. So these, basically give you a result that is as accurate as lab PCR, but they have the portability and the ease of use of a lateral flow test. And it's worth knowing that the FDA has just approved the first molecular sexual health panel for home use in America. So this is an over-the-counter test that anybody can buy and take home and test themselves for sexually transmitted infections, so gonorrhea, chlamydia, and trichomonas. And it's kind of seen as a Rubicon moment in the US because this is the first time that they've done this. And when you think about it, it's a really good thing because part of the barrier to detecting and treating sexually transmitted infections is that people don't want to go to clinics. So this is a good thing. And when you think about it, ultimately home testing, self-testing for infectious diseases is a real way of emancipating patients and levelling up health inequalities, because providing they're affordable, this means that no matter who you are and where you are and what your access is to your GP, you can get a test and you can get diagnosed and find out what it is you've got. So I'm going to wrap it up there, but this is a picture of Bob Dylan, and the title, some of you may have picked up that is a reference from a Bob Dylan song, Ballad of the Thin Man, And I've always really liked Bob Dylan, and my dad got me into Bob Dylan when I was a child, and this is him doing his first electric set at the Newport Folk Festival in 1965. So that picture's in there for you, Dad. Because of the time, I haven't had a time to talk about the clinical service that I and Rob and Julian and Sarah have developed over this time. But I just wanted to say I'm incredibly proud, of what we've done and the quality of the people that have come out the other side. And it's particularly heartwarming to me that we've now employed a lot of these people as consultant colleagues. So we've got Chris Mansbridge here and Tom Cusack and Nick Norton. We've got Adam Dale there and Vikram as well. And it's just great to see all these excellent trainees getting consultant posts with us. And also we've got a picture there from, this is my Christmas dinner. Alex is wearing a really excellent Christmas jumper there. And we've got a great cohort of new trainees and new SHOs, and it's a really great time to be here. And so, I'll just wrap this up there. I accept that my acknowledgement slide is really not adequate. There's a great many people that have been involved in that. I've tried to acknowledge everyone, and I've tried to acknowledge them as we go through, but I know there's people that have been really important in the research that I've not been able to name individually, and I do apologise for that. And most of all, what I need to do is thank my excellent family. And so this is Tamsin, my wife, and my two boys, Toby and Dylan, for being so supportive of me, and also my mum and dad, who I'm really pleased you guys were able to make it. We weren't sure that you were going to be able to, but it's great that you did. So thank you so much. And this is and also my sister here, who no longer dresses up as an Indian, as far as I'm aware. So thank you very much for listening.
Amazing. So, Tristan, thank you. I'm Diana Eccles, for those of you that don't know me. I'm Dean of the Faculty of Medicine, and I love inaugural lectures. It's one of the highlights of my month when I know it's an inaugural lecture is due, and you've done us proud. It's fantastic. Really, really. I always learn such a lot, and it's lovely to learn about the journeys that get people to where they are. And I just made a few notes as we're going along, because I didn't actually realise that you'd requested this lecture theatre. So I had Katie really didn't let on about that. So I think the Blake's 7 is a bit of a generational thing. So mine was Star Trek and John Pertwee, and was it a transponder that he had? Tricorder, but that was that Bones for his diagnostics. Yeah. So exactly. So that absolutely resonated. And what you maybe do know, but Boulderwood is now our engineering innovation campus. So that actually, you came from innovation, it's innovation again. And I think your thespian credentials do you proud, so well done. You've obviously learnt well, but you do know a lot of famous people actually as well, so I think that might be more than the average person. And JVT, so of course he came and did our Wade lecture here. And you weren't involved because it was right in the middle of all the COVID sort of lockdowns and things. Yeah. But what you might not know is that there was massive security around his and we did the interview in building 32, the engineering building, and he had to be shipped into the back under sort of secret guard and sort of ferried upstairs so that nobody could see him. But they didn't seem to need to send guards with him when we went to have a meal afterwards at the Harbour Hotel. So
I saw him recently, and he didn't have any guards with him there.
No. I think he was very pleased not to have all of that sort of security, and it was all to do with anti-vaccines and all of that stuff. And the other thing I really didn't know is that leishmaniasis is endemic in Spain. So I must tell our head of HR, who has a little holiday home in Spain, that may not be a healthy place to go. So yeah, I mean, I think I learnt a great deal about that. And the national data on COVID I hadn't seen either, so that was fascinating.
So really, really fantastic. And I think minus a beard, you really could be one of Blake's 7, is all I can say as a final conclusion. So I would just say that was a masterclass in inaugural lectures, really, really interested, really enjoyable. And thank you very much indeed. So I think everybody can join me in thanking us.
Thank you very much.
It's well done, Dad. And I think we have some drinks outside if people would like to come and mingle.
Brilliant, thank you. Thank you so much for listening. I do appreciate it.